Okay. We also have Sue Boreski. She's a familiar face at this table, even though we don't have a table. And she's the CEO of the Reh-Fit Centre and has been in that role since 2005. Casey Nietzsche has also been the executive director of the Wellness Institute since 2011 and was also involved in this study. Welcome.
Welcome. Thanks for having us. So thank you for the introduction, Stephanie, and thank you for Packham for inviting us here to talk about the findings of this study. My name is Ranveer, and today I'll be discussing the impact of the medical fitness model on long-term health outcomes. And I just want to give a thank you to our partners that were involved in the study. It was the Chronic Disease Image Center, the Wellness Institute, Reh-Fit Centre, the Seven Oaks General Hospital Foundation, the Manitoba Centre for Health Policy at the University of Manitoba, Research Manitoba, and the Health and Stroke Foundation of Manitoba. So I'm gonna start my presentation kind of giving some background. We all know it's well established that engaging in an active lifestyle and regular physical activity, irrespective of age and sex, is associated with a reduced risk of death. You're less likely to be diagnosed with chronic disease, and improves your quality of life. Now, despite these well-known benefits, the prevalence of physical activity is approximately only 50% in Canada. And the World Health Organization has acknowledged that physical inactivity has been recognized as the fourth leading risk factor of global mortality. Now, there's also evidence that there's a dose response effect, meaning with increased levels of a physical activity, you're more likely to not have poor health outcomes over your lifetime. And there's been studies that even shown that even low doses, very minimum doses of physical activity, are associated with great health outcomes such as survival. And there was a study done by Chi Wen where they showed that among 500,000 individuals in Taiwan, that even exercising at low intensity levels, about 10 to 15 minutes a day, showed a 15% lower risk of mortality. Now, given these possible health benefits, it's concerning that the majority of adults are not participating in regular physical activity. And this is specifically concerning because we know the prevalence of chronic disease is rising, and it's increasing, and this prevalence is increasing as you get older, as you age. And we also know that there's a demographic shift occurring as a higher proportion of adults are now entering the later part of life. And in Canada, older adults are the fastest growing demographic of the total population. So therefore, we need strategies and interventions to encourage physical activity participation so individuals can live longer, maintain functional independence, improve their health-related quality of life. And at a health policy perspective, it can potentially decrease the economic impact of results from poor health outcomes in physically inactive individuals. And it's estimated that physical inactivity is associated with an economic burden, an annual economic burden of approximately $27 billion. Now, one potential intervention could be the medical fitness model. And I'm going to talk a little bit about how the medical fitness model differentiates from your typical fitness centers. So traditional fitness centers have generally attracted the highly motivated, health conscious, and already healthy individuals. The medical fitness model targets individuals at risk of being physically inactive, such as older adults and individuals with chronic disease. In addition, the model does not only focus on physical activity, but how to modify other lifestyle factors such as nutrition, sleeping, stress, smoking. These facilities usually have appointed a medical director and have a close alliance with a hospital or healthcare professional. This allows for medical oversight, supervision, and guidance. With this alliance, the medical fitness model is able to bridge the gap between acute hospital care and long-term medical services, such as providing rehabilitation programs and programs directing and managing chronic diseases. They also have staff that's employed at these facilities that have a higher level of education and training based on certificates from recognized organizations and universities. And these guidelines are pretty much standardized across all facilities. Now, what does it entail to be a member at these facilities? So membership includes access to, cardio machines, weight training equipment, typically indoor track, swimming pool. They also offer group fitness classes such as yoga, cycling, interval training, strength and conditioning, recreational sports. Majority of the facilities also provide a personalized health assessment that's done annually, which includes a biometric evaluation, body composition, a nutritional and lifestyle assessment. And they also provide health education seminars such as nutrition, sleep, stress, and classes on how to manage chronic diseases. Now, in Winnipeg, we are fortunate to have two medical fitness facilities. One is the Reh-Fit Centre, and the other is the Wellness Institute. And I'm assuming some people are already familiar with these facilities or either have attended these facilities before. So what we looked at in our study was to see members at these facilities versus individuals who do not attend these facilities. Are they better off for long-term health outcomes? So we published this study last month in the American Journal of Preventive Medicine, and I'm going to kind of take you through how we went about doing that and kind of describe the results and those implications. So our study design for this study was a retrospective cohort design in which we went back in time and looked at outcomes as they occurred. And it was an attention to treat analysis, which means that once you were put in the intervention cohort, so once you were considered a member, we followed you in that timeline over the study period. So from the Wellness Institute and the Reh-Fit Centre, we were able to collect data on 19,300 members, which is a huge cohort size. We were then able to link these individuals using their personal health identification number to health administrative databases at the Manitoba Centre for Health Policy through the University of Manitoba. And we were able to link these or control for almost 500,000 Manitobans in Winnipeg, which is, again, a huge study cohort. Now, our study timeline began in January 1st, 2005, and our study end date was December 31st, 2015. So a long follow-up period, about 11 years or so. So our population groups, our intervention group were new registered members. So if you had previously been exposed to any of these centers, you were excluded. So you wanted to see the effect of this intervention in newly registered members. We also wanted to look at possibly a dose response effect. Now, we were fortunate enough to actually have scan data. So we knew in a month how many times these members actually visited these facilities. And based on their attendance, we were able to stratify them into these three groups. So we decided to stratify on visits less than 1 per week, which we would consider low frequency users, 1 to 3 visits per week, which we consider moderately frequent attenders, and then greater than 3 visits per week, which we considered were high frequency attenders. And we were going to see the differences between these groups. Now, in order to make sure that we can actually look at the effect of the intervention, we got to make sure when we're doing these population studies that we're controlling for confounding variables between the two groups. And so we tried our best to control for what we could. So in our study, we controlled for age, sex. We controlled for socioeconomic status, which was based on your income quintile. We controlled for the year that you entered the study, and we controlled for about 19 comorbidities, and they're listed here. There are a whole host of them, and these comorbidities are the most common comorbidities, and these comorbidities also have really well been validated in administrative studies previously, so they were easy to attain in the Manitoba Centre for Health Policy databases. Now, our outcomes, we wanted to look at hard clinical outcomes. So we wanted to look at all-cause mortality, so time to death, and also the differences in the risk of hospitalization between the two groups. Now, these are our baseline characteristics between the two study groups. So the controls were slightly older, with a mean age of 47 years, slightly a higher proportion of males of 48%. The intervention group had higher prevalence, or a higher proportion of them had a previous diagnosis of myocardial infarction, diabetes, cancer, depression, hypertension, and coronary artery disease. And there's also a differences in income quintile. So as you can see in the intervention group, there was less individuals that were from a lower socioeconomic status versus a higher socioeconomic status. And so then we had to find some statistical modeling to make sure that these groups are balanced before we start looking at the effect of the intervention. And in the next slide, you see when we did apply that, both groups were balanced on majority of these variables, which was a good thing. So now we could actually look at the effect of the intervention moving forward. So what were the results? So when it came to all-cause mortality, we actually had to split up the time period into the first 651 days and then after 651 days, just because the risk that we saw, there was a difference between earlier versus late. So in the first 651 days, we found that members were associated with a 60% lower risk of mortality compared to controls. And then after 651 days, members were associated with a 48% lower risk of mortality compared to controls. Now, in our dose response analysis, in the first 651 days, low and moderate frequency tenders were associated with about a 60 to 63% lower risk of mortality, and high frequency tenders were associated with a 16% lower risk of mortality. Now, over time, after 651 days, low and moderate frequency tenders were associated with a 46 to 47% lower risk of mortality, and high frequency tenders were associated with a 74% lower risk of mortality. When it comes to hospitalization, members were associated with a 13% lower risk of being hospitalized compared to our controls. And here's where we actually saw that dose response effect. So we found that individuals that attended these facilities more frequently were also associated with a decreased risk of hospitalization. So low frequency tenders had a 9% lower risk, moderate frequency tenders had a 20% lower risk, and high frequency tenders had a 39% lower risk. So in summary, being a member at a medical fitness facility may lower your risk of death and being hospitalized compared to matched healthy individuals, and that more frequent use of these facilities may further lower your risk of hospitalization. Now, these results are quite powerful, and we're hoping that these findings at least hopefully start the dialogue or the discussion with policymakers, health policymakers, government policymakers, to maybe see that if this medical fitness model could possibly be a primary and secondary intervention strategy to promote physical activity. And not only that, maybe open up the discussion as this model being a possible lifestyle modification. In the future, maybe primary care physicians can have this discussion and maybe recommend these facilities as a positive health behavior. And there's also opportunity here as well for these facilities to be integrated, to have integrated and continuous care. So individuals who are at hospitals and they're going through rehab may be referred to these facilities to continue the rehabilitation and promote that physical activity in these very vulnerable chronic disease populations. Another big implication is that hopefully this model may relieve some of the economic burden on the healthcare system. So as I discussed earlier, the total annual healthcare cost of physical inactivity is about 27 billion annually. And a huge reason of this is hospitalization. So hospitalization is a major cost driver of healthcare. And we found, as I mentioned earlier, that the more frequently you went to these facilities and the more you engage in physical activity, your risk of hospitalization decreased. So there's a potential cost saving to the healthcare system. So what this means is that this medical fitness model may be an alternative intervention strategy to promote positive health behaviors. And I think there's a really big opportunity here to especially target at-risk populations, such as patients with chronic disease, older adults, and individuals from a lower socioeconomic status. And as we see, these are the type of individuals that are not attending these facilities. So is there a possibility here to maybe subsidize membership or provide incentives to get these vulnerable populations at these facilities? So one of the strengths of these studies is that we were able to have a very large sample size to look at the effect of this intervention. One other interesting part of the study was we were able to objectively measure attendance. Now, in previous literature, majority of these studies either give out surveys or questions where physical activity participation is asked from the individual. And so this results in recall or social desirability bias, which individuals try to answer more positively. But we were here, we knew exactly when these individuals entered these facilities and how frequently they entered. Another big strength of our study was that we had a very long follow-up. So we had a long time to actually follow these patients and see where they occurred these outcomes, such as mortality and hospitalization. We also were able to link to provincial health databases at the Manitoba Centre for Health Policy, which have very high data capture rates. Now, there are definitely some limitations of our study. So unfortunately, we couldn't control for everything. There's certain lifestyle factors such as smoking, alcohol use, things like personality factors, frailty. These are things that just wasn't captured in these databases, and we weren't able to control for. However, we did control for very severe chronic diseases such as liver disease and chronic pulmonary disease, which may have served as a proxy for more severe disease outcomes that result from alcohol use and smoking. We also couldn't take into consideration the physical activity that was occurring outside of these facilities. And currently, our dose response effect in our model is only based on how frequently you attended. So we actually don't know what kind of activities these individuals were doing at these facilities. And is that effect from physical activity alone? Is it from the counseling they may be receiving? Is it just because from social factors such as meeting a friend there and then spending some time socializing? Or is it a combination of all those things? So hopefully in the future, we can build on this and look at maybe building a cost-effectiveness study, looking at if we did subsidize these memberships, would it be cost-effective for the overall population? And then maybe look at possibly the differences between member profiles, so the types of activities they're doing at these facilities, how long they're doing it, what's the intensity of the physical activity, maybe gives us a little bit more insight. And maybe studies some of the social factors of individuals going to these facilities, meeting individuals, talking, and seeing what that impact might be as well for long-term outcomes. And also comparing this intervention to other interventions that are out there and seeing, are there any differences? So what we're currently working on right now is looking at more outcomes. So we're currently working on a study that's going to be looking at long-term mental health outcomes for members and looking at possibly if there's a dose response effect. looking at outcomes such as the differences in rates of ED visits, physician visits, prescription drug use, and possibly in the future looking at subgroups such as older adults or specific chronic disease populations. And that is my presentation for today, and I am open for questions.
Well, that was a great presentation. It's really nice when real data supports what we already are pretty sure that we know. And this is the first one that I've seen in a really long time that's not self-reported data. So that's an amazing differentiation that you made between other surveys and data collection research projects and this one.
Stephanie, maybe just on behalf of, I'm sure Casey got stuck at work. It's, as you all know right now, it's pretty chaotic in fitness centers right now with COVID. Are we open? Are we closed? And all the restrictions. So, but just on our behalf, first of all, I want to thank Ranveer and the team for their work on this. And this all started from actually, if some of you remember, at Canada NZ Health Sciences Centre, when we were asked to all come together and look at physical activity as a whole. I think you were there, Stephanie, and others. And Dr. Alan Katz was presenting in terms of, how, measuring physical activity in Manitoba and the importance, et cetera. And then I guess he heard about the database that we had in the Wellness Institute, and because we have so many years of data. And one of the things I want to emphasize is the importance of having the data. Because we have been doing this for years. And one of the benefits of being, or one of the emphasis of being a medical fitness facility is we do gather a lot of data, but we did have the expertise of some researchers, and Ranveer got totally into that as a student of Dr. Katz, and but now he's our lead researcher in this. And so he had the pleasure of hearing all our comments throughout this whole thing. What about this? What about this? What about this? And then he'd have to go back. So this was like a process of, I don't know, what was it? It seemed like 2 years, Ranveer, was it? It's over 2 years that we were looking at what we could get.
Yeah, I would. It's been about a 2 to 3 year process. I spent the first 6 months actually as a student when I was doing my master's, just cleaning the data. And making sure we have the frequency of attendance. So that was the whole process itself. And then, yes, going back and forth, deciding on how we want to stratify members and what's appropriate and what's not appropriate, what we should control for, what we shouldn't control for. So it took a while, and then also there's a whole side of research when it comes to publication and the writing aspect, which can take a while as well. So, however, I think in the end, the results speak for itself, and at the end of the day, hopefully, we can maybe hopefully change policy moving forward.
Yeah, so if we didn't have that data and we didn't have someone like Ranveer totally focused on it, it would have been difficult. And you're right, Stephanie, we all know it's there, but to show it happened in Manitoba and to collect them. One of the things I always hear every time I say, oh, it's really important, they'll say, oh yeah, but you have to look at the social determinants of health. And it's because these are people with money and people can afford it. And I don't know all the words, Ranveer, but there's 2 ways they controlled it to make sure it was very tightly controlled for all those factors that people keep telling us in terms of their economic, where they live, all those things were all controlled for. And there was 2 different ways they controlled it. And you could mention it afterwards, Ranveer. I can't remember, but they explained it to me so that people could not use that. Well, that's because people who go to these centers are from this status or, this, and they controlled for all that, which was really helpful, right? Because that's what we always get, that people who go to fitness centers are not the average person. And, those are the reasons. And the second thing is, because we're quite connected to healthcare, we have the advantage that we do link in terms of we can link our data without revealing who the person is to their medical records. So because we do health assessments and we gather health information, we do have their personal health information. And so Ranveer and his team kind of are able to pull that together in a secure way that no one's divulged who it is. So it could be like Sue Bareski starts today, this is my background. And then it's like Ranveer and his team in retrospective look at my history over the times that I was at a particular center, either wellness or Reh-Fit, and see how we did. So I found it fascinating and so exciting because we have now proof. So they can't say it is because they were here. Ranveer did mention, which is of course for us, is like, what about this person just came up and talked to their buddy? Because it's, it's their swipe in. I don't know if they're going to yoga or they're whatever, but what does it matter, right? They've improved. So just I think it's probably a collective, knowing they're supportive, knowing that it's a community, knowing they have guidance, knowing they have education. So I think it's probably a whole bunch of things. It would be nice to be able to collect. You can imagine Ranveer would probably have a job for 20 years if he had to clean up all our data on assessments. But again, there's lots of possibilities with this data that we have, and it's not often you can get 10 years of that many people. And that's just because of the kind of software that both sites use in terms of gathering data. So we're hopeful, all of us, that it's helpful for just physical activity in general for all of you in one way or another, because I know some of this data is a result of just activity and some of the services you offer. So it's just, we have the ability to connect that to healthcare, which is really critical when you're talking to policymakers.
That is absolutely correct. So we did record this session today. We will be providing it to you. Feel free to share it, because I think there's a lot of people who want to hear it. They want to see it explained, so that you can take off some of those naysayers maybe who have a specific idea on how the data was collected or used. And I think we're going to stop the recording now. Thank you so much.